Hello everyone and welcome to another part 1 question set. Let's get going. What is the antidote for digoxin toxicity? Well, the antidote is digoxin immune Fab fragments, but I'll tell you that we really don't use that very often because it's incredibly expensive, not that easy to find. Most of the time we try to normalize the potassium and the magnesium, give lidocaine for any arrhythmias, and sometimes we'll use cardiac pacing as well. Next question, what are some of the circumstances in which information is HIPAA exempt, meaning that your health information can be shared with another party? So there's a long list. Things like child abuse, birth or death information, disease reporting of state-mandated reportable diseases, public health disease surveillance, and then state-sponsored disease intervention activities. So an example of this would be a scenario where a physician reported to the state information regarding a patient having an STD or tuberculosis. The state then contacts the patient to determine close contacts that might also have been contracted that STD or TB to protect other people. Also, schools are exempt, meaning they can ask about vaccination status. Next question, Hydatidiform mole is the most common precursor of what ovarian germ tumor? And then what tumor marker is monitored after the dilation and curettage of a Hydatidiform mole? So the answer is going to be choriocarcinoma. And then what tumor marker are we going to do after we actually do that DNC? Well, it's going to be the beta HCG. That needs to be monitored, making sure it goes all the way back down to normal, because if it stays elevated, you're going to worry that you didn't get all of that pregnancy, and that little piece left over could potentially progress to a choriocarcinoma. Next question. You are reading a research article about the prostate-specific antigen test, and it mentions that the PSA blood test is associated with a high false positive frequency. In your own words, explain what false positive means. Well, a false positive occurs when the test is positive even though the disease is not present, and this test is falsely positive. Next. A young woman complaining of easy bleeding and menorrhagia was referred by her OB-GYN for workup of her bleeding disorder. Your preceptor tasks you with determining the cause of the patient's condition. Compare the clinical findings of platelet disorders to those of coagulation factor defects. So what you need to remember here is that platelets act first and form a platelet plug. So the first part of hemostasis is the formation of that platelet plug. And then that nasty coagulation cascade kicks in to generate a fibrin clot that is going to last a lot longer. So if you have a platelet disorder, you'll have a prolonged bleeding time, and then PT and PTT will be normal. If you have a coagulation factor defect, the platelets are still working normally generally, so they'll be able to form that platelet plug, and bleeding time will usually be normal, but the prothrombin time and the partial thromboplastin time will be prolonged because these are determined by the coagulation cascade and your coagulation factors. So with a coagulation factor defect, bleeding time is normal, and either the PT or the PTT will be prolonged, or both PT and PTT can be effective. It just kind of depends on which factor you're dealing with. And then clinically, platelet disorders can cause kind of small hemorrhages, such as epistaxis, petechia, purpura, that sort of thing. Coagulation factor defects can cause more major bleeding, like bleeding into joints, like hemarthrosis, like we see with hemophiliacs, or intracranial hemorrhages, that sort of thing. Next question, how does MRI differ from CT imaging? So MRI uses no ionizing radiation, but CT does. So kind of just like an X-ray, and we actually try not to do a lot of CTs on pregnant women unless we absolutely have to, because that ionizing radiation is dangerous for developing fetuses. MRI is better for looking at soft tissues like the brain, the spinal cord, joint ligaments, and cartilage. If you need to look for something like an ACL tear, you're probably going to want to get an MRI of that knee. Now, CT is better for bone detail and recognition of blood, so excellent for bleeding, especially in the brain. Now, a patient with symptoms of a stroke comes to the ER, you're probably going to get a CT scan really quickly to see if there's any hemorrhage in the brain. Now, with MRI, you're using a kind of big magnet, so you can't have any metal in the imaging room, but with CT, metal is not a problem. And then on MRI, bones are going to show up gray. On CT, bones are going to show up very white, just like an X-ray. Next question. A 45-year-old woman presents to the ER with complaints of chest pain, a racing heartbeat, and dizziness. Examination reveals a heart rate of 120 beats per minute, BP of 116/74, and 20 respirations per minute. The patient is diaphoretic and anxious. An initial EKG reveals ventricular tachycardia with shifting sinusoidal waveforms. What is this classic EKG finding? What are the possible causes of this patient's condition? So this is torsades de pointe, which means twisting of the points. So you might have recognized the description of that shifting sinusoidal waveform, or sometimes polymorphic VTAC, or sometimes variable amplitude VTAC. They'll call it a lot of different ways. Or they might just give you that 12-lead EKG or a rhythm strip, and you should be able to recognize that as well. So what are the possible causes of this patient's torsades? Well, basically anything that prolongs the QT interval can increase the risk of torsades. Now, lots of drugs will prolong the QT interval, some antiarrhythmics, some antibiotics even. And then a hypokalemia or hypomagnesemia can increase the risk of torsades. So if you see a patient with this, one thing that you're going to do is check the electrolytes. You're going to give IV magnesium, maybe IV potassium if they're off. There's also some congenital long QT syndromes caused by cardiac potassium channel defects or cardiac sodium channel defects. Next question. A patient of yours with recent complaints of weakness, pallor, craving for ice chips, and tachycardia has a history of chronic hemorrhoids. What do you immediately suspect is the cause of this patient's anemia, and how do you treat it? Well, that pica, or pica, depending on who you're talking to, which is the craving of non-food substances such as ice chips, is a classic feature of iron deficiency anemia. Now, here the history of chronic hemorrhoids is a flag for rectal bleeding as a cause of the iron deficiency. Now, the treatment would be iron replacement, possibly a colonoscopy. This is an older patient to evaluate for colon cancer. Next, what enzymes do obligate anaerobes lack? Well, obligate anaerobes lack catalase and or superoxide dismutase. Now, superoxide dismutase converts oxygen radicals to water and hydrogen peroxide. Catalase breaks down hydrogen peroxide to form water and oxygen. Next question. What embryological structural abnormalities might account for multiple miscarriages? What structures arise from the paramesonephric ducts? What other name is given to the paramesonephric duct? So one structural problem that can result in multiple miscarriage is incomplete fusion of the paramesonephric ducts, and that can cause a bicornuate uterus, which can have varying degrees of severity. Now, what structures arise from those paranephric ducts? So you have the fallopian tubes, the uterus itself, upper portion of the vagina. And then what other name is given to the paramesonephric duct? It's also called the Mullerian ducts. All right, that's it for the set. I hope you learned something. I'll see you next time.